I'm a consultant psychiatrist, and I'm a consultant psychiatrist, and I am the CEO and clinical director of MindWell, which is a private mental health care center. I'm also assistant professor of psychiatry at the University of Toronto. It's my great pleasure to run the first MindWell online journal club. We are basically testing this format, gauging the level of interest from our colleagues. What we saw was that there was a gap in something regular that is outside of the scope of the private sector and outside of the scope of the government sector, really just physicians and allied health professionals coming together to discuss something scientific without any funding from the pharmaceutical industry. So we decided to do this. We are doing it ourselves, and we hope you enjoy it, and we welcome your suggestions after this first session to make future sessions better. We hope in the future that we can bring this on-site as well, that can be in person. With that, I will go ahead and just do some housekeeping things, tell you how the proceedings today are going to run. And I'll ask Dr. Sami to just check every once in a while if there's any new participants that need to be admitted in the waiting room. I assume maybe they can enter now directly. We have about 34 participants, so that's fantastic, and I hope they grow over time. What we're going to do is we're going to spend an hour with you. We're going to try and present for about 40 minutes and leave about 20 minutes for discussion. In the discussion, what I would encourage you to do is use the chat icon and send your messages to everyone. And that would include your questions. What I'll do at the end of Dr. Sami's presentation is pick some of the questions. We'll try to go through as many as we can, and we go around answering them. If there's something that's an interesting discussion, you can also, there's a raise hand icon in the bottom if you want to actually participate verbally, and then we'll ask you to unmute yourself, or we'll unmute you, and then you can participate. I know there's many people here who are psychiatrists, who are psychologists, who are other doctors of other fields, other allied health professionals. So there's a wealth of knowledge in this room, and it's not just me and Dr. Sami sharing. We want to hear from you as well. With that, let me present Dr. Sami. Dr. Sami has been a wonderful addition to the MindWell team. He's a consultant psychiatrist, originally from Tunis. He trained in Tunisia, where he was top of his class. He then went to the university, the Lausanne University Hospital in Switzerland, which is ranked one of the top hospitals in the world in the latest rankings, and did his continued his psychiatry training there. He's been involved in research in many different countries, including with the World Psychiatry Association. He worked as a consultant psychiatrist in Qatar at the Hamad Medical Center. And he's involved in many research studies, many publications, and has a wide variety of interests, including psychopharmacology, geriatric psychiatry, dementia, medical education, and so many other things, trauma therapy. He is trained and certified in EMDR. So really a man who has many hats within psychiatry and mental health, and it's really a pleasure to be hosting him. The title of the paper today is called Comparative Efficacy and Acceptability of 21 Antidepressant Drugs for the Acute Treatment of Adults with Major Depressive Disorder, a systematic review and network meta-analysis by Professor Andrea Cipriani and colleagues, published in the Lancet in 2018. So with that, I'll hand over to Dr. Sami. The one word I'll say is this is a very timely presentation. As we try to become more precise in our treatment of depression, in our biological treatments, we want to be precise and follow that Hippocratic rule of first do no harm, and also have high efficacy for our patients. So we hope that this journal article answers some of that and also opens some more questions for future research. Thank you all for attending again, and please take it away, Dr. Sami.
Thank you, Dr. Muhammad. Thank you, everyone, for joining us tonight. So tonight, as you know, we are going to discuss like a very famous meta-analysis of antidepressants, like efficacy and acceptability of antidepressants in the acute treatment of adults with major depressive disorder. So I think even if you've only read a few articles or a few meta-analyses in your life, you've probably come across this meta-analysis because everyone is talking about it. Like your professor is probably talking about it. The medical representatives are always talking about it. If you go to any conference, like you will see slides talking about and mentioning this meta-analysis. So I think you probably heard about or even read this meta-analysis, but my mission here is to convince you that maybe you have never read this meta-analysis, at least that carefully. So we actually chose this paper, Dr. Muhammad and I, because it tries to answer a very frequent question in our clinical practice. So every day we're diagnosing them with MDD, but then we are at least thinking, which antidepressant shall we choose? So shall we, for example, go with the evidence? So there are so many studies that we have read. Shall I go with my intuition or with my empirical guidance? So I've tried antidepressants A and B, and they've never failed me. At the same time, I have the thought of like my older professor, telling me TCAs are the best antidepressants out there. And then let's not forget the friendly medical representative was always saying our drug is actually the best antidepressant. So with all these thoughts in mind, how can we come up with the prescription with the best or with an optimal prescription for our patients? So here is the plan for this presentation. So in fact, to introduce the topic, we really have a plethora of antidepressants, and we need to select one, usually, at least initially, one antidepressant for our patients. But we really need guidance. We're like, it's a black box for us. We're confused, and we really need guidance. And what's better than a guidance from scientific evidence in the era of evidence-based medicine? So with this evidence in mind, we will be able to probably to select the best treatment for our patient. So, and if we need scientific evidence, obviously we need the best of the best. And as you can see here, so meta-analysis is the highest quality of evidence we have in terms of evidence-based medicine. So it's higher than any other thing in this pyramid, as you can see here. So this is a paper that can truly answer our question. So let's talk about the method first, because of course the quality of any paper depends a lot on the quality of the method. And here I can tell you, so I mean, the title already tells you that this is a network meta-analysis. And just to keep you engaged, I want you to ask the question, what is a network meta-analysis? I think you can see a poll and then you can answer the question. So what's the network meta-analysis? Is it a meta-analysis comparing one drug to placebo? Is it a meta-analysis comparing multiple drugs to placebo? Is it a meta-analysis comparing multiple drugs using head-to-head comparisons or trials? Or is it a meta-analysis comparing multiple drugs directly and indirectly? Okay, so just give you 1 minute maybe, or a few seconds. I think most of you got it right. So it's a meta-analysis comparing multiple drugs, both directly and indirectly. So I'll just end the poll. So the idea here, so to understand the network analysis, we first need to understand what the conventional meta-analysis. In a conventional meta-analysis, we have different studies comparing a drug A versus placebo or versus another drug B, and then we can somehow sum up all these findings into one big study called meta-analysis that compares A to B. In a network meta-analysis, things are a little bit more complex because so we can have a study comparing A to B, and then we can have a different study comparing B to P, that's the placebo. Then we can also have a third study comparing C to B, and then we can have indirect comparisons between C and A and B, and C and P. So if we include all of these comparisons into one network, into one meta-analysis, then this meta-analysis is a network meta-analysis. So of course, to like have or to include studies, they needed to look like for studies in different, like in a huge range of databases, all the usually used databases. So they tried to be as comprehensive, as thorough as possible. They used the following search query, of course, for the meta-analysis. And what's really important about this meta-analysis is that they also added a manual search. So they also looked for published, unpublished, and ongoing RCTs in international trial registers, in websites of drug approval agencies, and so on and so forth. So it's very important for meta-analyses to actually also add or include unpublished trials, because as you know, there's always something called like publication bias. And in a publication bias, so publication bias basically means that negative trials are less likely to be published than positive trials. So like the authors here tried, of course, to look into the unpublished trials, and they tried to include them in their like meta-analysis here. And of course, they tried to see like or to look for articles from inception to January 8, 2016. Remember, this is a rather old article from 2018, but then this is still the most recent meta-analysis of antidepressants we have today. So like the other like thing that's important to discuss here is the inclusion exclusion criteria. So in this meta-analysis, they included double blind RCTs, only using one antidepressant, comparing one antidepressant versus another, or comparing one antidepressant versus placebo. They used doses within the therapeutic range. Then they, of course, only focused on MDD, only focused on adults, and they allowed rescue medications if equally provided. However, they excluded quasi-randomized trials, incomplete trials, and any trials which had more than 20% of participants with bipolar depression, psychotic depression, treatment-resistant depression, or any serious concomitant medical condition. And we're gonna talk about this in the limitations later on. So what are the primary outcomes the authors looked into in this meta-analysis? As the title says, clearly, efficacy and acceptability, okay? So let's first define efficacy. Efficacy is usually defined by response rate. So what's response rate? Try to like see through a poll. So what's the response rate? So is response generally defined in antidepressant trials as a reduction in the depressive symptoms score that's clinically relevant? Is it a reduction of at least 50% of the depressive symptom score, or is it a normalization of the depressive symptom score? I'll just give you a few seconds, I think. And I think most of you got it right. So it's a reduction of at least 50% of the depressive symptom score. Normalization, of course, refers to remission usually, and then a reduction that's clinically relevant. This is not a very precise term, so we need something very precise, of course, as a primary outcome. So it's usually a reduction of at least 50% of the depressive symptom score. So the second outcome that's important, and this is a very common, this is very common for all meta-analyses, I think. So first we talk about efficacy and then acceptability. So what's acceptability? This is the next question. So what is acceptability? Is it tolerability? Is it a measure of efficacy and tolerability? Is it discontinuation rate due to serious adverse effect, or discontinuation rate due to any adverse effect? What's acceptability? I think it's very important to really understand the primary outcomes. If we don't understand the terms that are being used here, we don't understand anything from the meta-analysis. I always remember one of my professors of philosophy used to say that most of our problems in this planet are due to us not understanding the exact terms, the exact definition of the words we use. I think this is a very good example. So we can see that like we have very different answers here. Most people said tolerability or discontinuation rate due to any adverse effects, which are actually similar. So tolerability is a discontinuation rate due to any adverse effect. It's 1 minus discontinuation rate due to any adverse effect. But acceptability is not tolerability. Acceptability is a measure of efficacy and tolerability. It's discontinuation rate due to any reason. So due to adverse effect or to poor response. So it's like a measure of both efficacy and tolerability. Okay, so keep this in mind. Acceptability here does not mean tolerability, does not mean side effects. It means how likely are the patients to discontinue the drug for any reason. And patients can discontinue the drug either because it's not efficacious or because they have side effects. So the secondary outcomes, there's like plenty of them. The most important ones like were the following. So you see here, the third secondary outcome is actually a tolerability outcome. The other acceptability is not tolerability. I think this is one of the key messages here. So here you can see the flow chart. So they included 522 double-blind RCTs in total after, of course, like examining thousands and hundreds, like thousands of records. So here you can see the network meta-analysis of eligible comparisons, both for efficacy here in A and for acceptability in B. So for efficacy, you can see, for example, okay, so for both, you can see that the circles here are in fact proportional to the number of assigned participants. The width of the lines here is proportional to the number of trials. So you can see, for example, that for certain antidepressants like fluoxetine, paroxetine, there was like very large sample size, whereas for other antidepressants like nifazodone, for example, here we had very small sample sizes, and this will matter a lot afterwards in the results section, of course. So let's move, I think, to the slide that you've been, all of you, I think you've been waiting for this slide. So which antidepressant has the highest efficacy, the highest response rate? So now we know what's the response rate. It's a reduction of at least 50% in the symptoms of depression using a score, of course. So now, I mean, take a look. This is a forest plot of efficacy. So here you have all ratios. So the neutral line is 1. So anything that's here, like to our left favors placebo, anything that's to our right favors the active drug. So take a look and tell me, how can you read these results? How can you interpret these results? 1 second. Okay, so we have a poll here. So when you examine this forest plot, what can you say? Can you say that amitriptyline was more efficacious than all other antidepressants? Can you say that reboxetine was not more efficacious than placebo? Can you say that there were no significant differences between antidepressants? Or can you say that fluoxetine was the most studied antidepressant? This is a tricky question as well. I think you've seen this slide before, for sure. So in so many conferences, so many presentations, they will give you this slide, but then like they will interpret it the way they want. So just be aware of this. So we're gonna see exactly how we can interpret these results. So most of you said here that amitriptyline was more efficacious than all other antidepressants, which is obviously wrong. So the correct answer was actually fluoxetine was the most studied antidepressant. So here you have like a confidence interval, and here the square here is proportional to the number of participants. You can see that fluoxetine then paroxetine had the highest number of participants, had the highest sample size. So this is true. But then amitriptyline was not more efficacious than most antidepressants, and we'll explain why. So all antidepressants were more efficacious than placebo. I mean, not a single confidence interval crossed 1. However, amitriptyline, mirtazapine, I mean, all of these confidence, not all of them, but most of them actually overlap. And if they overlap, you can say that that amitriptyline was, for example, more efficacious than mirtazapine or than nifazodone or sertraline, because these confidence intervals overlap. So don't just look at this numerical value. Look at the whole confidence interval, and this is a huge meta-analysis with more than 100,000 participants. So it has a very high power. So it has a very high ability to detect any differences if they existed. And yet the statistical difference, or this difference, was not statistically significant for most comparisons, with a few exceptions that you will see later on. Okay, so let's move now to acceptability. Like it's the overall dropout rate again, dropout rate due either to like poor efficacy or to side effects. It's just patients discontinue the medication for any reason. So how can you read this? So when you examine this forest plot, again, do you see that antidepressants other than clomipramine did not have more side effects than placebo? Do you see that agomelatine and fluoxetine had even fewer side effects than placebo? Do you think that participants were as likely to stop most antidepressants as to stop placebo, or that attrition rates were high with TCAs? Okay, just give you a few seconds. Okay, so most of you said agomelatine and fluoxetine had even fewer side effects than placebo. Again, we're talking about acceptability, not tolerability. So we can't say that based on this slide at all. And this is not very like, we can't really imagine that drugs have like fewer side effects than placebo. This is not usually logical, okay? So the correct answer is actually participants were as likely to stop most antidepressants as to stop placebo. So if you you see that most, except for clomipramine, fluoxetine, and agomelatine, most antidepressants here, their confidence intervals cross the one. So for most antidepressants, there was no difference with placebo with regards to acceptability, which means that patients on antidepressants were as likely to drop out as were patients on placebo. The three exceptions being agomelatine and fluoxetine, where participants were less likely to drop out. So these had better acceptability. And then clomipramine had lower acceptability, which means that patients on clomipramine were more likely to discontinue the drug than patients on placebo. So this is how you can read the acceptability side. So, of course, this is like the very complex table that will explain the few statistically significant differences that exist between antidepressants. And we'll try to go through this table together. So the dark side here, so the darker...
Dr. Sami, sorry to interrupt. Some participants are saying it's hard to hear you, and I think it's because you're using a voice-activated mic. So when you speak loudly, it's clear, but when you speak softly, or I guess you can use a headset so that it's not. I don't know if you're using the mic that's in the camera.
I'll switch.
Or
I'll switch the. Okay, I'll just switch the. Okay, I think things are maybe clearer now.
Yes.
Okay, so so in fact, so you can see here the darker part refers to acceptability. The this part refers to efficacy. So when you have a look here, so these are the, of course, they are just in alphabetical order, the different antidepressants that were included in this study. So if you look, for example, at just efficacy, so this part. So agomelatine, there was only one difference. Agomelatine was more effective than reboxetine. This was the only statistically significant difference. For amitriptyline, it was more effective than fluoxetine, then reboxetine, and then trazodone. Bupropion was more effective than reboxetine, and then trazodone. If you go to citalopram was less effective than escitalopram because it's less than 1. Clomipramine was less effective than escitalopram. Duloxetine had no significant differences with any other antidepressant. Escitalopram was more effective than fluoxetine, then fluvoxamine, then reboxetine, and then trazodone. Fluoxetine was less effective than mirtazapine, then paroxetine, and then venlafaxine. Fluvoxamine was less effective than mirtazapine. Mirtazapine was more efficacious, sorry, and it's not effective, it's efficacious. We're talking about a trial here. So mirtazapine was more efficacious than reboxetine and then trazodone. Paroxetine was like more efficacious than reboxetine and trazodone.
And then you can see that reboxetine was less efficacious than both venlafaxine and vortioxetine. Trazodone was less efficacious than venlafaxine and vortioxetine. So these are the statistical differences. Anything else was not statistically significant. Again, the same thing applies for acceptability here. So you can see, for example, that agomelatine was better in terms of acceptability than many other drugs, than amitriptyline, than clomipramine, than duloxetine, than fluvoxamine, than reboxetine, than trazodone, than venlafaxine. And then you can, of course, this is how you can read this table. So, and then it's a very complex table, very difficult to understand. So this is why they came up with a better visual representation of the results. So the better representation is, in fact, using these graphs. So here you have, in like the y-axis represents the acceptability, and then the x-axis represents the efficacy. So as you can see here that the best antidepressants would be here. So they would have the best efficacy and the best acceptability. Here, they include all studies. So we'll just focus on this first graph first, and then we'll talk about the second graph. So if they included all studies, we will see that, like, visually, maybe the best antidepressants might be amitriptyline here, 2. Number 13, maybe mirtazapine here. Maybe 15, paroxetine was not that bad. But then the problem with this graph is that they said that heterogeneity was a bit high when they included all studies, which means they included both head-to-head trials and head versus placebo, drug versus placebo trials. And they think that this is because of very high differences in terms of response to placebo between drugs. So this is why this is not very easily interpretable, and then this is why they came up with this second graph, in which they eliminated any studies comparing the drug to placebo, and they only focused on head-to-head studies, which means studies comparing active drugs to each other. So, and you can see here that visually, again, number 21 is vortioxetine, is the highest here. Number 8 is escitalopram. Number 3 is bupropion. Number 1 is agomelatine. Number 13 is mirtazapine. Number 15 maybe is paroxetine. So you get the point. However, we always need to take these results with a pinch of salt. Why? Because you can see the confidence intervals here. They are very large and they overlap to a great degree. So you can see like how large is this confidence interval. So these differences are mostly not statistically significant. And to add insult to injury, the certainty of evidence for these results was at best moderate for certain comparisons and was low to very low for many other comparisons, especially with either the very new drugs or the very old drugs. So this is why these are results that we need to interpret with a lot of caution. So what are the conclusions from this study? So the conclusions that we were waiting for someone to win the prize of the best antidepressant with the highest response, with the lowest dropout rate. We waited for some antidepressants to be completely banned from our formulary, but then this is not what the meta-analysis reached. So actually, the meta-analysis said that, okay, there might be some antidepressants that maybe we might applaud for, because they might be a little bit better in terms of efficacy and in terms of acceptability. Vortioxetine, escitalopram, mirtazapine, paroxetine, agomelatine, and sertraline. But then again, we take this result with a pinch of salt because, again, most of these results, most of the differences were not statistically significant. And then maybe the meta-analysis might point towards reboxetine, trazodone, and fluvoxamine maybe having a lower response rates and having lower or higher, dropout rates. But then again, we need to take this with a pinch of salt. So the true conclusion is that all ADs were more efficacious than placebo. This is clear from this meta-analysis. But then the effect size was modest overall. So the overall Cohen's d, which is like a measure of the effect size, was 0.31, which is modest, which means, I mean, this modest effect size is not because the response rate was low on antidepressants. It's actually due to the fact that response to placebo was very high in most studies. And this is something we're going to talk about again. So only agomelatine and fluoxetine had better acceptability than placebo. And then only clomipramine had worse acceptability than placebo. And then there was no big difference between antidepressants at the population level. There were differences, of course, we talked about them, but the differences are not as big as some people want you to believe. So what are the strengths of this meta-analysis? So it was not industry funded. It was as comprehensive as possible. It included 522 RCTs, more than 100,000 participants. So more than half of the studies that they include were not published. And this is a big strength because they try to include any unpublished trial. These unpublished trials are often negative. This is why they are not published, and they try to include as many of these as possible. So there was no publication bias in this meta-analysis. And then they tried to assess the quality of the included trials in a rigorous manner. They tried to assess the quality of evidence, again, using a known framework. And they found overall low to moderate heterogeneity for most, like overall, like for the heterogeneity was moderate when they included trials that included placebo as an arm, and then it was rather low when they deleted the placebo studies and they just focused on the head-to-head studies. And this is why they included these results separately in the paper. And then they did not find any difference between sponsored and non-sponsored studies. This is also important. So what are the limitations of this meta-analysis? Well, it included studies only until January 2016. This is now an aging meta-analysis that needs, of course, an update. Usually they update meta-analysis every 5 years or so. So far, this meta-analysis has not been updated yet. They did not include any MAO inhibitors. We know that these are drugs that have good efficacy in general. So the certainty of evidence was low to moderate for most comparisons, even though they tried to pick the best studies out there. Still, the certainty of evidence was not very high. They only included people with MDD only, and then only as initial treatment, not people who were already on medications who were on other medications, for instance. Short duration, 8 weeks. Inclusion exclusion criteria, of course, will create an artificial pool of participants, and these participants are different from real-world patients, as we will discuss later. And then, of course, all of these results at the population level. Now, extrapolating these findings to an individual level is not always easy. So, and this is the art actually of prescribing, and we'll talk about this later as well. So what are the take-home messages from this meta-analysis? I think the first take-home message might be, so if you still have a rule in your mind saying that the first-line antidepressant is an SSRI, then now you understand that you need to bury this rule forever, because this meta-analysis showed that atypical antidepressants are at least as good or even better in many aspects than SSRIs. So why are we depriving our patients from drugs that are better in terms of efficacy, of acceptability, and we're sticking to SSRIs? So this is not always logical. And then I think another comment I would like to add, the strength of placebo. So you see here that the effect size was modest, but it was modest because the placebo answer or response was very high. So, and we need to understand more probably how this placebo effect works. Maybe if we could enhance the placebo effect. We know that every medication out there, not just in psychiatry, every medication out there has a placebo component in its effect. And the placebo component is not negligible. And we maybe, if we understood the placebo effect better, maybe we could find ways to enhance this placebo effect. So after all, so okay, we surely need evidence to like select the best medication out there for our patient. But then we also need to, at an individual level, we need to take into consideration the patient's characteristics. If the patient, like the age, the gender, comorbidities of the patient. Of course, like we don't see patients without comorbidities. We usually see patients with diabetes, with hypertension, old patients, patients who are pregnant, patients who are breastfeeding. So all of this has to be taken into account, obviously. And then gradually we're moving towards a neurobiology informed, let's say, prescription. So depressions are not alike. We now can understand, we can hypothesize at least that there are different types of depression, and every type of depression can have its own neurobiological print or fingerprint. So if we understand or at least we have a hypothesis from a neurobiological point of view, we know which neurotransmitters, for example, we need to target. This is also important in the choice of the antidepressant drug. So another thing is, okay, in English, we often use adverse effects and side effects interchangeably, but I'd like to think that these are very different terms. Adverse effects are bad, side effects can be good or bad. They are not like side effects or any effects beyond the primary effect. So for example, sedation with mirtazapine can be like a positive side effect, if you'd like to say. So we can use the side effects of the drug to help patients with certain symptoms. If your patient really has like severe insomnia, maybe mirtazapine can be considered. If they have weight loss, maybe mirtazapine can be considered because it increases weight, for example, and so on and so forth. Of course, pharmacokinetics also are to be kept in mind. If your patient is likely to skip a dose or two every now and then, maybe fluoxetine or vortioxetine are better than venlafaxine for this patient. And obviously the genes as well. So pharmacogenomics in our center, our clinic, we are now using like pharmacogenomics for certain patients. Of course, not for every patient, but for difficult to treat patients, we need the like pharmacogenomic data to guide us, choose the best antidepressant for them. So let's go back to so our patient here. So in fact, we need to put all of these information together. Also, we shall not forget that depression is not only treated with antidepressants, it's also treated with psychotherapy, with social interventions, with lifestyle changes, with neuromodulation. We also need to apply probabilistic thinking to all of this, and we need to reduce our cognitive biases. We often have we have our own cognitive biases when prescribing. We are used to this drug being effective, or we're used to this drug being associated with certain side effects. So if we combine all of these together, then we can get like an optimal prescription for our patient. And by prescription, I don't just mean medications. Prescription can also include lifestyle changes, psychotherapy, neuromodulation, social interventions, and so on and so forth. Thank you for your attention. And this is my business card for those who want to contact me. Thank you.
Thank you so much, Dr. Sami. That was an excellent presentation. And I don't think I've heard this article presented so well, ever. I've read the article many times and seen it presented, but really this was a thorough dissection. Thank you all for attending. I see some people clapping also. So that you know, this is the Zoom era. We can't really see people clapping, but I see a lot of people using the clapping emoji or reaction. So let me remind you, you can type your questions in the chat. You can also raise your hand using the icon to raise your hand. And I will start with some of the questions that are typed. And then for the next 20 minutes, we'll just, we started 5 minutes late, so we'll try to end at 9:05. Let me make some comments first, and then I will read the first question. So my comment overall is that one of the challenges with these types of articles is that we're trying in science, I guess, to apply a one-size-fits-all, basically answer this question, what is the best antidepressant, to something that is not a one-size-fits-all. And I think in your summary slide at the end, both the limitations and others, you made a good point around this, which is these were short-term trials, 6 to 8 weeks. For me, that's maybe why paroxetine and mirtazapine did well in terms of tolerability. But I think if this trial was 6 to 8 months, you would have those patients on paroxetine and mirtazapine complaining that they've gained a lot of weight. But then also, sometimes we see some of these medications that did well on efficacy and tolerability, like agomelatine or vortioxetine. You give it to a patient and they don't tolerate it, or they just don't respond. So the individualization or the precision approach to psychiatry, I think, is going to be very, very important to psychopharmacology. With that, let me take some of the questions. So first question here, what about mirtazapine or vortioxetine as a first-line treatment? Do the results support that, or would the results support that? What are your thoughts based on this paper, Dr. Sami?
So I think it's like the paper clearly says that you can basically use any antidepressant as first-line treatment. There's no evidence to support that certain antidepressants should be first line and the others should be second line in general at the population level. Now, at an individual level, obviously, if you take into account like the patient's characteristics, comorbidities, etc. So I think obviously
Family history of response.
history, family history. So there's so many, like the cost as well. And the cost can vary from country to country. So I think mirtazapine and vortioxetine can, of course, be a first-line treatment in many cases. I personally use both of them in many cases as first-line treatment. Obviously, like depending on all of the features we talked about, these two drugs, anyway, I mean, as per this meta-analysis, they were among the best antidepressants, in terms of efficacy and acceptability. Of course, now mirtazapine, of course, I mean, for weight gain, etc. Maybe, as you said, like the trial was short, etc. Also, even for the efficacy, actually, the trial might have been a bit short. But then, in general, these are like, at least with the evidence we have, these can be first-line treatments. Absolutely.
You know, along that lines, there's another study that looked at what side effects tend to lead to the most dropouts. And the side effect that leads to the most dropouts, in other words, probably is an indication of tolerability and acceptability, is sexual side effects. It's not weight gain. It's not. So what's interesting in this trial, mirtazapine, vortioxetine, agomelatine, they all did well, and those are antidepressants known to have less sexual side effects than other antidepressants. So I wonder if that's what boosted their tolerability. What are your thoughts about that? Oh, sorry. Maybe it's better to stay unmuted. Let me just unmute you again. Oh, where did you go? Sorry, 1 second. I lost Dr. Sami's icon. Hold on. I apologize. 1 second. There we go. Ask to unmute.
Okay.
Yes, sorry, go ahead. Yeah.
So yeah, so I think like in general, yeah, like bupropion as well. Bupropion was also
that's right.
one of the best.
It did well.
So I think I mean, it's one of the. I mean, I didn't include the tolerability slide because it was included in the like supplements, so it was not part of the like core paper, let's say. But yeah, like the sexual side effects, as you mentioned, are like known to cause early dropouts from the study. So absolutely, and I think we need to take this into consideration. Maybe we don't like routinely assess people for sexual side effects, or we don't even assess them. We need to assess them at least for their like sexual history, even before starting them on antidepressants. Because if the patient, for example, has premature ejaculation, then maybe we need to consider paroxetine, for example. But then so
or any traditional SSRI that
for example. So
all right, so next question, can you explain more about pharmacogenomics? So maybe take a stab at that and maybe I'll chip in as well.
Okay, so pharmacogenomics, so now we are able to have a list of genes that we know can interact with the response to a certain drug. So these genes can be pharmacokinetic or pharmacodynamic. So there are genes that will tell you, for example, that this patient is an ultra-rapid metabolizer, a rapid metabolizer for this drug, etc. And there are genes that are pharmacodynamic. So they will, for example, tell you that the receptor, this receptor, for example, or this target of the drug is, for example, has a mutation, and then the drug is unlikely to give a good response, for instance. So now there are different kits, different panels with like a panel of different genes And this panel is regularly updated, actually, with like the new evidence. And so the idea of the pharmacogenomic kit is that you will actually have different, let's say, columns or different groups of medications. This applies not just to antidepressants, by the way. This applies to all psychotropic drugs and to all drugs, basically, in medicine. So you can understand, like with the pharmacogenomics, if the patient, for example, is an ultra-rapid metabolizer for these drugs. So they will basically give you different columns, like a green column to tell you that these, I mean, the patient will behave with these medications as usually. And then you have like a yellow or an orange column where you might need some adjustments in terms of dosage, either by increasing or decreasing. And then you might have a red as well, a red column where, you know, there's like, for example, a very high likelihood of serious adverse events, or for example, it's an ultra rapid metabolizer of a certain drug. Maybe it's very difficult to get this patient to like a therapeutic level and so on and so forth.
Yeah. So a very good explanation. What I might add is that it's already been used in medicine in a lot of different areas, and actually recommended. For example, while I was a resident in Toronto, the FDA and Health Canada came out with guidelines that any patient of Han Chinese descent should not be given carbamazepine without pharmacogenomic testing for looking for haplotype B1502, because that would be a predictor of developing Stevens-Johnson syndrome with carbamazepine. In oncology, pharmacogenomics has been used for some time, and so it's way far ahead of psychiatry. So sometimes I hear vigorous debate about pharmacogenomics, and you know, sometimes there's accusations that this is, you know, there's genetic companies that are just trying to make a profit off of this. Obviously, anything in medicine that has a product, you're going to have business people trying to make a profit of it. This is the way the world works. However, as informed scientists, I think what we need to do is, I mean, when someone says to me, are you for or against pharmacogenomics? I would say that's like asking me if you're for and against an ECG, or are you for or against a CBC? I'm not going to do an ECG in a young person who has just sprained their ankle, right? I'm going to do an ankle X-ray, maybe an MRI. So it's about choosing the right tool for the right situation. And so it's not for or against, it's what data can you get from it. So I think that's the way to look at it. Okay. How clinically relevant are the, sorry, go ahead.
Yeah, there's a meta-analysis that clearly says that like you multiply the rate of response with pharmacogenomics by 1.8. So you almost double the rate of response if you use pharmacogenomics. So there's evidence for like its effect.
Yeah, and the question around pharmacogenomics is cost, right? So what I would say is, if pharmacogenomics cost less than 100 KD or even less than 50 KD, so for reference, let's say less than $100 US dollars, because you know people are from different countries, it would be a no-brainer. We would be doing pharmacogenomics for most patients. The problem now is cost, and that's why we have to be more careful about selecting it. I believe in the future that we're going to be doing pharmacogenomics for most patients, not just in psychiatry, in most of medicine, because the genetic data will be better, plus the cost will be down, and as happens with any technology. How clinically relevant are the differences in efficacy and acceptability reported between antidepressant drugs? Are the observed differences meaningful in terms of real-world treatment decisions and patient outcomes?
I think this is a very important thing that comes out of the meta-analysis. So the differences were actually tiny between antidepressants. In most cases, in terms of efficacy, we generally say that, I mean, we need at least a difference of 3 on Hamilton D, it's like a 17-item scale, at least a difference of 3 to like have a clinical significant like difference, clinically relevant. So a statistical difference does not always mean a clinical difference or clinical, like sometimes the difference is statistically different, but it's not clinically significant. I mean, this difference is not clinically significant. So in these cases, it's true that in most cases, the differences were like small between antidepressant. And this is why one of the main conclusions that we can come up with like from this meta-analysis, that all antidepressants are fine. It just depends on, you just need to like, use targeted care. You need to tailor your prescription to your patient. There are some antidepressants that might be slightly better in certain regards than others, but then overall, the differences are not huge.
That's a great answer. I actually don't have much to add to that. Next question. What do you think about guidelines like the CANMAT guidelines? So the CANMAT, for those who are not aware, is the Canadian Network of Mood and Anxiety Treatments. CANMAT guidelines that recommend starting with sertraline, escitalopram, mirtazapine, venlafaxine, agomelatine, citalopram due to their superior efficacy.
Okay. So I'm not aware of this exactly. I thought that in the CANMAT they also like recommend other medications as well. But anyway,
That's what I thought as well. I think, but that's my reading of the CANMAT guidelines, that they don't say specifically these. They really list almost all antidepressants other than tricyclics and MAOIs. Having said that, some of the accompanying editorials to the CANMAT guidelines, and I've seen some of them. One of them is, I think, published in the American Journal of Psychiatry. Talks about these specifically, just mining the data, sifting through the data, that these might be superior. I think there's an editorial by Sagar Parikh et al. that talks about this point that Dr. Ibrahim is raising.
but also I think it's not just in terms of efficacy, it's also in terms of efficacy and tolerability, because if you
Right.
just MAO inhibitors are very they have like high efficacy, we know that. The TCA is
The best efficacy, actually.
but then
Yeah.
we don't use them.
Yeah.
I mean, we don't use them
Right.
like as a first line, almost never,
Right.
because of like tolerability issues. But I think I don't know why. I mean, at least according to this meta-analysis, I mean, you can see that vortioxetine, bupropion are also like good antidepressants actually, and can be used as first line. I mean, citalopram was actually inferior to escitalopram in many cases. Like, the difference was at least statistically significant, especially with the drop in price of escitalopram due to generics. I think that citalopram, I mean, I don't know why citalopram even still exists, to be honest.
Right. Yeah, I agree. Especially that there's evidence that it's easier to dose and less side effects and a slightly higher efficacy with escitalopram.
So,
I mean, so the question, let's just speak openly. Sometimes you wonder how much of the escitalopram versus citalopram, like omeprazole versus omeprazole, is really scientific versus, pharmaceutical industry, what they call patent cycle management. And patent cycle management means when they're about to run out of the patent, then they release the enantiomer, or they release. And so I think there's a bit of both. We can't say it's all this or all that. I don't know if you agree with that.
yeah, absolutely.
Yeah. There's two questions in French. Maybe we'll take one of them. We do have speakers who speak French. Most of the people here don't speak French. But let me ask one more question in English, and then for people asking in French, maybe if you don't mind, we'll just take one question in French, because I think 90% of people here don't speak French. Yeah. But let me take one more question in English, and then I'll read. I actually don't speak French. My sister speaks it well, but I don't. So patients always ask us which is the softer, in quotations, that's not my quotations, that's the person who's asking, antidepressant. So so there's really no clear answer. I guess what they're saying is which one is milder, which one tends to be and I think at face value we might say something like agomelatine, but then every once in a while you see someone's liver enzyme spike with agomelatine. So what do you think? What is the answer?
I think there's a cognitive bias in the question. So we have a cognitive bias saying that, okay, a softer antidepressant is an antidepressant with fewer side effects and which is probably also less effective than others. We assume sometimes that efficacy and, I mean, very effective drugs tend to be more, or I mean, to have more side effects and vice versa. So I don't think there's like a soft antidepressant in terms of what's soft antidepressant exactly, like an antidepressant with fewer side effects. As you said, I mean, do you prefer a side effect that's very common, like nausea, but that's usually harmless? Or do you prefer having a very low probability of very serious side effects, like I don't know, for example, as you said, hepatic toxicity, or like for example, with lamotrigine, you can die of Stephen Johnson.
Stephen
It's very
Johnson,
rare.
yeah.
It's very rare, but
But so it can happen, yeah.
But it can happen. So I don't know exactly how would we define this, but in terms of like, at least let's stick to the meta-analysis. Again, they're like agomelatine and fluoxetine were actually the least likely to be discontinued by patients, at least initially. So this shows also that they are well tolerated. So they are but then most antidepressants did not differ from placebo in terms of discontinuation, which basically means that most antidepressants are well tolerated overall.
Okay. There's two questions in French. I don't know if you can see them, Dr. Sami. Maybe
Yeah.
pick one of them and go ahead and
Okay.
answer it in French.
So the idea is
we
that,
apologize to the
okay,
non-French speakers.
yeah.
Yeah.
So why is the effect modest in general, and how is it logical that acceptability is the same as placebo? And why SSRIs as first line? So, okay. So in fact, modest, as I said,
Oh, so you'll answer it in English. Okay.
Yeah.
I'm guessing the speakers maybe
Yeah,
speaks English
I will
or can
try
understand
to.
English if they're, yeah.
So,
Yeah.
I mean, if you want, I can answer in French as well. But
I'm,
then,
I'm guessing probably like only less
yeah.
than 10% of people speak,
So
so maybe better to speak
I'll
English.
answer in English. So in fact, the effect is modest, as I said, mainly because the placebo effect was high in most studies. And this is a trend in like antidepressant trials. And there are so many studies about this. Why is the placebo effect so high? So the number of patients who like respond is actually not bad at all. But many patients also respond to placebo, and this is why the effect size was modest. Acceptability, again, acceptability is a combination of tolerability and efficacy. So it's just means that people discontinue the drug. People can discontinue the drug because they believe it's not effective or because they have a side effect. And they do discontinue placebo as well because sometimes they feel that they are on placebo, or sometimes they have side effects even in placebo. There's nocebo as well.
Yeah.
I mean, overall, agomelatine and fluoxetine had higher acceptability, which means that people who were on them actually continued or were more likely to continue them than people on placebo, which means that probably it's a combination of good efficacy and no or few side effects initially, at least. SSRIs first line, as I said, according to this meta-analysis, this is not true. I mean, there's no clear evidence to say that we should use SSRIs as a first line. In certain countries, they say that based on cost, but again, there are now generics for many atypical antidepressants. Bupropion is cheap, mirtazapine is cheap, so not all like atypical antidepressants are more expensive than SSRIs necessarily.
Okay. Just in the sake of time, and I'll ask you to keep the answer efficacious. Someone is asking, I'll take this as the last question. I was not here from the start. Did the RCT, well, it's not an RCT, it's a meta-analysis, but did the study, I'm going to rephrase, did the study use minimal effective doses or other dosages? So that really goes down to the granular level data. I mean, the studies included, did they use standardized dosing or not?
So they used like any study. So they included any study that used those within the therapeutic range as per the usual references. So the BNF, they mainly use the BNF as a reference. So any drug that was like used within the therapeutic range, for example, escitalopram 10 to 20, for instance, let's say. So they included the trial, whether it's like a fixed dose or sometimes it's a flexible dose. So they included all of these as long as the dose was within the like acceptable, they said. So they in the supplements they clearly say exactly, there's a huge table saying for each antidepressant which is what interval they deemed like good or like within the therapeutic range exactly, and the different references. So they compiled 2 or 3 different references, and then so basically it's not the minimal effective dose, it's a dose within the range.
Thank you so much. I'm going to share one last poll, but before that, I want to thank you all for attending. For us, this was a really, as our center grows, what we really wanted to do is have a sense of social responsibility to our colleagues at MindWell. We don't want to be a center that is just seeing patients clinically. We want to also be advocating for mental health, fighting stigma, improving knowledge. We see that as part of our goal, and not every goal, whether it's public or private, has to have a monetary drive, and for us it's certainly not that. Of course, you have to keep the lights on and people paid, but and that's how the world works. But I think there's more to life than that, and there's more to science than that, and that's why we all became doctors in the healthcare field. So thank you for attending. Let me share this last poll, which is, should we repeat this journal club at regular intervals? In other words, and it's anonymous, so you don't have to answer yes, but let's see what people are saying. And my prediction is that there was a gap, and hopefully we help everyone filling that gap. So we're getting 100% yes so far, with more than 70% of people participating. So Dr. Sami, thank you for the great initiative. Really, Dr. Sami spearheaded this initiative, and he's spearheading a lot of our research and educational initiatives at MindWell. Thank you once again. Have a good night. Happy holidays and national days. God bless you. God bless Kuwait in this special time for our country. And Ramadan Mubarak Muqaddaman to everyone. Thank you. Have a good night.